I look forward to sharing with you some things that I hope will be helpful in your practice with your patients, and a little bit about the biology of really an area of science and medicine that I believe is emerging to be an understood cause of a lot of very diverse chronic disorders. And so we'll talk about that. And I'll also pause a little bit in between here if you have some questions in between. And you certainly can do, as Amy suggested, type those in the chat. We'll try to make this a little less formal. So we're going to talk about a connection between infections, the immune system, and the brain, and we'll go through some case studies, but we'll also look at the biology, because there's medical models here that help understanding the complexity of these disorders and why they have eluded a lot of treatment in various cases. So what we're going to cover today is the biological background of how infections can trigger neuropsychiatric symptoms. And then we're going to look at why certain infections can trigger these immune-mediated neuropsychiatric disorders. And you may be familiar with PANDAS or PANS, neurologic Lyme or post-treatment Lyme, and even more recently, the emergence of post-COVID long COVID syndrome. We'll go over some case studies of patients, and we'll talk about some of the therapeutic categories that have shown clinical effectiveness when treating these immune-mediated disorders that are secondary to an infection. And then we'll look at the biological targets in the Autoimmune Brain Panel and specifically identify these as to their biological function, and then how they can aid your diagnosis of these disorders and how they can help in directing therapy. So with that, we know that inflammation and immune dysfunction really do have significant effects on many different disease states. And it's likely that many are emerging in the sense where it's more relevant to things than we previously understood. Some individuals even believe that most chronic diseases are linked to inflammation. And in a broader sense, basically, it's the immune system. So there is a difference between acute and chronic inflammation. So acute inflammation is a response to many different stimuli, such as infections. But chronic inflammation, as we know, is something that can result in many of these other chronic disorders, like autoimmune diseases, neurologic diseases, and cancer, rheumatoid arthritis, cardiovascular diseases, and many others. So what we're talking about here is not acute inflammation. We're talking about chronic inflammation and the stimulation of the immune system over a long period of time. So just to put this in perspective, inflammation and antibody production is our immune system's response to both pathogens and different types of injury. So as you know, we have an innate immune system, which is our non-specific but first responder to any type of pathogen or any type of injury. And then over time, the more specific adaptive immune system begins to kick into gear, and it provides long-term memory of things that such as memory B cells and the ability to see and respond quickly to a similar infection or a similar organism. Hence is why we have vaccinations and many of the other ways in trying to shorten the time between a second onset of an infection and the adaptive immune system. Most notably, the production of antibody titers, and those will help understand how effective a person's immune system is against responding to different types of injuries or insults or pathogens. So now we ask the question, can infections trigger an autoimmune response that leads to neuropsychiatric disorders? Well, here's one article here that appeared in JAMA Psychiatry back in 2019. And it chronicled a study in Denmark of over 1 million individuals who were followed from birth to age 18. And in this study, what they looked at was that if a patient or person was hospitalized for a severe infection, that they found that the risk of developing certain types of mental disorders increased by more than 80%. And these included schizophrenia, autism, OCD, ADD, ADHD, personality and behavioral disorder, oppositional defiant disorders, tic disorders, and several others. So, in an accompanying editorial, they asked the question, how could exposures to infections affect the brain mechanistically to give rise to mental disorders? And they responded that circulating autoantibodies that enter the brain via a compromised blood-brain barrier bind to neurotransmitter receptors is a potential explanation. And this mechanism has been proposed in pandas and other mental disorders. And so we're going to talk a little bit more about these circulating autoantibodies and these neurotransmitters that these autoantibodies can interfere with. And we know that a large portion of these neuropsychiatric disorders are caused by an infection-triggered autoimmune dysfunction. So you may be familiar with pandas and PANS, and what we believe is that these are medical models for other immune-mediated neuropsychiatric disorders. And as you can see in the JAMA Psychiatry article, these included many of these other so commonly understood disorders that are diagnosed really by symptoms. So if you've heard of PANDAS, we know that it's a pediatric autoimmune neuropsychiatric disorder associated with a streptococcal infection. And Dr. Susan Sweeto was the one who pioneered this particular nomenclature and understanding of this disorder, as well as a number of her colleagues and others that resulted in the term PANS. So the first 50 cases were published back in the late 80s and the early 90s. And it was specifically focused on individuals, children, who had a sudden onset of OCD and behavioral changes, but were preceded by a strep infection. Now, nomenclature can tend to be confusing. We mentioned what PANDAS is, but it's understood now that other microbes other than strep can trigger similar symptoms. And it's believed that environmental and other biological factors can do the same. So when you combine those two, you really don't have PANDAS, but you have then what's been now named as PANS, or pediatric acute onset neuropsychiatric syndrome. So Lyme, Babesia, Bartonella, Mycoplasma, and those infections would not be able to be labeled as a PANDAS diagnosis, but it would fall under PANS. And so this is where some of the confusion might come. But if you're an adult, neither PANDAS nor PANS applies to that diagnosis because, again, you have to be in the age range for pediatric. So other terminology like ANDL, that sometimes is called adult neuropsychiatric disorder associated with Lyme, or autoimmune neuropsychiatric disorder associated with Lyme. But we do know that in a broader sense, that we're really talking about an autoimmune encephalopathy secondary to an infection. Sometimes you'll hear it called basal ganglia encephalitis because of the target in particular that these autoantibodies are targeting against. But if you kind of summarize all of this, really we're talking about an immune dysfunction that results in neuropsychiatric and behavioral symptoms secondary to infection. So I hope this helps in the understanding, because sometimes the nomenclature and the terminology gets confused in the sense where if you don't fall into these criteria, you might be succumb to a similar model, but it's not necessarily that exact diagnosis. So if we look at biologically, how does that occur? Well, we all know everyone comes in contact with different bacteria, virus, fungal infections over their lifetime. And we also know that through both the adaptive and the innate immune system, over time, we respond with antibodies that recognize these infectious organisms. However, in certain individuals, again, certain individuals, antibodies that they generate are directed against a portion of these organisms that have a common sequence with a portion of our body. We call that molecular mimicry. Normally, the body will shut those down because it says this is self and it's not non-self. But in these certain individuals, the antibodies they generate are against those epitopes, which is a portion of this protein, that look like or identical to a neurologic receptor. When that happens and the blood-brain barrier is crossed, these will interfere with these common epitopes, in these cases on various types of neurologic receptors, and through what might be better understood as a friendly fire, they cross-react and interrupt the brain function. And so you will see manifestations of different types of neuropsychiatric symptoms, maybe anxiety, aggression, rage, OCD, depression, hyperactivity, and many others, depending upon the target in which they're directed against. Standard of care typically will be treating patients with these neuropsychiatric symptoms or different types of symptoms with symptomatic treatments. However, what we do know and we see, and you probably have too, is that they are treatment resistant, meaning that they don't respond to these types of treatments, and it's understood because that this is an immune-mediated dysfunction rather than a typical psychiatric issue. And so we also see that patients will respond to various types of immune modulators, anti-infectives, anti-inflammatory agents, and then we do see and patients will witness some remarkable recoveries even after suffering for a very long time. So if we look at the science and the medicine over time, more and more of these anti-neuronal or autoimmune antibodies that are targeting neurons are being discovered. You may be familiar with the NMDAR receptor, the N-methyl-D aspartate receptor, the GAD65 receptor, the aquaporin, the acetylcholine receptor, and these trigger very severe neuropsychiatric symptoms. And the underlying root is an autoantibody targeting a specific, in these cases, neurologic receptor. And now there's growing recognition of the connection between these infections and the immune system and neurologic and psychiatric and behavioral disorders. And what you can see here is in this JAMA or Frontiers in Psychiatry article, this infection anti-neuronal antibodies in psychiatric disorders. But you can also see microbiome involved, psychological factors, chronic inflammation, and you can see these things are interconnected. But we're going to talk really about this particular pathway here today. So in medicine, we know that many of these different symptoms, as listed here, can and are categorized into these different diagnoses that are identified as symptomatic. But for instance, Tourette syndrome, the definition for that is that motor or vocal tics for more than 12 months with some other criteria is one of the criteria for the definition of Tourette syndrome. Very similarly for Asperger's, epilepsy, autism, similar. Again, though, what we're talking about is these being diagnosed entirely on clinical presentation rather than biology. And we do believe that it won't be too long until in the future, these will be diagnosed and identified by the targets that they're directed against. We see that happening for cancer, rather than the cancer being identified by the organ in which the cancer is growing in. It's now becoming more common to see it being diagnosed and identified as the pathophysiological mechanism or the target because once you understand that, you can direct a treatment towards the underlying root cause. And this is really what precision medicine is, and this is what we work on here at Molecular Biosciences. So there are common neurologic, psychiatric, and behavioral disorders, such as listed here and in the previous slide. And through testing over 15,000 patients now since we've been open, many of these have had these presumptive diagnoses, and we've found that 85% of those patients that we have tested have been identified as immune-mediated cause. Now, does that mean that 85% of all of these disorders are autoimmune? Probably not, because these patients that we get for testing have seen between 5 to 15 doctors and have not responded to traditional medication. So we do believe that there is an overall bias in the sense where if patients have not recovered, they will begin looking for other alternative testing, and this is how they come to us. But to say that a good portion of many of these different disorders could have an underlying autoimmune etiology is probably a true statement. Now, one of the things that contributes to this difficulty in identifying them, and it's unintentional, but medical specialization unintentionally has made it difficult to diagnose and treat these types of disorders. Because we see in specialization, psychiatry is separate from immunology, separate from infectious disease, and separate from neurology and other disciplines. Whereas we do know that the body does not really distinguish between these specialties. In this case, infectious diseases contribute to the psychological state, the psychiatric state, which can affect the neurologic state, and is an underlying result of immunology. So we do know that it is important to have cross-disciplinary and collaborative medical care, because what can happen through this is to accelerate the diagnosis and the treatment of these chronic disorders. So one thing that we do know is that autoimmune neuropsychiatric disorders that are triggered by infections is not a new phenomenon. And interestingly, PANDAS and PANS, although recently coined in the late 80s, early 90s, is really not a new medical model, because Sydenham, Korea, back in the 1600s, a name from Thomas Sydenham's work, used to be called St. Vitus's dance. And it was seen that children, in these cases, would have these abnormal movements, they loss of fine motor control, and all this emotional changes and emotional control, even back then, and it was understood that these different disorders here, specifically Sydenham, Korea, was triggered by a group A streptococcal infection. And we do know that it also triggers rheumatic fever, but Sydenham, Korea is a neurologic manifestation of acute rheumatic fever. In maybe about a quarter of the patients who have acute rheumatic fever can and do manifest Sydenham, Korea. Now, we don't see that as much in the United States. Is seen in other countries. And so this phenomenon of an infection triggering the immune system to attack parts of the brain, resulting in neurologic psychiatric behavior, is not new at all. And the challenge that you face in patients with these conditions is this idea of never thinking outside the box. And so often, as mentioned, many of these patients will come to us after through various physicians, clinicians, and practitioners who have identified that this could be an underlying autoimmune condition. So some of these autoantibodies that we'll talk about attack the basal ganglia and trigger parts of that brain in an inflammation. This was a study that was done in children, looking at an MRI on many children, because sometimes the accuracy of these are a little more difficult. But if you look at the grouping and the tendency, for an inflammation in the caudate, the putamen, and the globus pallidus. You can see in patients with OCD and tics that were triggered by a strep infection, they have inflammatory indications, whereas not in the thalamus, which is not in the basal ganglia. And interestingly, if you'll note, the function of the basal ganglia is responsible for voluntary motor movement. Hence, you can see the correlation with potentially with tics. Procedural learning, you can see correlation with brain fog and cognitive complaints, cognitive functions, and then emotional functions. Basal ganglia is involved with that. So you can see sort of the connections between the different types, anxiety and fear and phobias and things like that. And even eye movement and mydriasis, you can see that in certain patients. So there is a really good direct correlation between the function of the basal ganglia and the symptoms that patients would exhibit that have these autoimmune antibodies. So let's talk briefly about the infections. Certain infections show up more frequently than others in patients that have these infection-triggered autoimmune neuropsychiatric syndromes. Strep, obviously. And the reason for strep is because there's some common sequences between the M protein and certain parts of the basal ganglia. Influenza A is one, but we also know with influenza A, you'll see a correlation in some cases with patients who end up with narcolepsy. This was more common or occurred more frequently with certain types of vaccinations of influenza A. Varicella, mycoplasma, Borrelia or Lyme, Babesia, Bartonella, Coxsackie, and others. Now, we also see multiple other infections, but you do need the ones that trigger the immune response to be directed against cross-reactive targets in the brain, which these tend to have similar sequence homology, and we're looking in the research side to identify more of those sequence homology. So briefly, let me share with you molecular mimicry, because this is an underlying process that we believe underlies a lot of autoimmune responses. So it's a process that occurs when there's sequence similarities between foreign and self peptides that get the immune system to react against those that are really also common to self. So there are only 20 letters of the protein alphabet, and if you look at a sequence of an organism and parts of your body, there will be places in which these sequence letters correlate with each other. And that's just because you only have, excuse me, 20 letters, and this occurs too in areas if you would take different types of maybe books or things you read or letters or things like that. So with that in mind, we know that antibodies recognize what we call epitopes on infectious agents. And again, there is a series of proteins, peptides, or combinations of different types of molecules. And then once that's recognized, the immune system is stimulated to replicate, and clonal expansion occurs, B cell replication or B cell memory B cells occur, and you have this long-term immunity. So what happens if that epitope of a bacteria, let's say it's strep and it's the M protein, and a part of the M protein is identical to a part of the dopamine D1 or D2 receptor? Well, once that's made, you will see a cross-reactivity between that and the receptor. And again, this is the phenomenon of molecular mimicry. And so there's an autoimmune response that occurs through molecular mimicry. And as I mentioned in the case of group A beta hemolytic strep, the M protein, which there's about 100 different serotypes, and the group A carbohydrate have really, in this case, the M protein shares sequence similarity to parts of the proteins in the heart, which hence you can see rheumatic fever occur. And again, similar things with basal ganglia, which is why Sydenham chorea is the neurologic manifestation of rheumatic fever in certain patients. But you can see joints, arthralgia, kidney, and others. So molecular mimicry in practical terms is the inability to recognize self from non-self. And so understanding that is helpful when you're looking at how did this occur so that you can understand and then treat the underlying roots of what's happening in these patients. So one of the things that we do at Molecular Biosciences is we do research and development and clinical testing on patients and serum with those that present with immune-mediated neuropsychiatric disorders. And we do this in order to be able to segment patients into those who would respond with immune modulators, anti-inflammatory agents, and anti-infectives, and those who would not, but would respond to traditional psychiatric medications, because they're all presenting with similar symptoms. So let me share with you a few case studies. Here's an 8-year-old girl who had numerous psychiatric symptoms. She had abrupt onset of OCD, vocal tics, poor concentration, sensory, motor abnormalities, emotional ability, a whole host of things, including dysgraphia, which is the fine motor movement interruption. And the parents also reported urinary and sleep problems. Patient was tested in the Autoimmune Brain Panel. Her lysoganglioside GM1 antibodies directed against that, and autoantibodies directed against tubulin, which is an intracellular protein that's heavily concentrated in brain cells. She had a relapsing, remitting symptoms. She was diagnosed with anxiety, OCD, and an unspecified disorder of immune mechanism. Many patients do have a family history of some type of immune dysregulation. The ASO titers were not remarkable, anti-DNase B were not remarkable, and had normal IgE titers. Again, remembering that there could be multiple triggers for different infections. So just because, let's say, a strep test is negative does not necessarily mean it may not be an infection-triggered autoimmune condition. The other thing is strep can exist in any orifice of the body. So there was significant for 2 recent streptococcal infections, as you can see here, with high fever, sore throat, sinus pain, and cough, and a history of air infections, sinus infections, and idiopathic fevers. And so you can see family history, positive for mycoplasma, autoimmune disorders, allergies, frequent and bacterial and viral infections. This was a case that typically was caught a little earlier because often the immune system isn't fully ramped up in this case. She was treated with 1 course of azithromycin with rapid improvement in her symptoms, and all of the symptoms resolved and returned to baseline within 2 to 3 days of treatment. We retested her. All of her elevated antibodies returned back to baseline. So this is the type of case we would like to see. Patient caught early, treated early, and then recovered. Unfortunately, the majority of the cases are patients in which they come after seeing, in this case, what I mentioned, 5 to 15 doctors, and still haven't responded or gotten well. So this is a little bit different case here with a 16-year-old girl, severe OCD and tics, and restricted food intake. Abrupt onset at the age of 11, so another 5 years of dealing with this. And the food restriction typically is more of an OCD than an identity issue or an image issue, because typically these are fear of food contamination, fear of choking, some other phobia about food. And tics, choreiform movement, poor concentration, cognitive difficulties, sensory abnormalities, mood dysregulation, again, urinary urgency and frequency, and dysgraphia. Unfortunately, her behavior prompted 6 calls to the local police. So patient was really, really severe, and parents were struggling. She had an elevated calmodulin CAM kinase activation. This is actually an enzyme that's in neuronal cells that we culture and pulse chase with radioisotope. And basically, the important thing to know is the elevation and activation of this enzyme is triggered by an antibody. Why is that important? Well, calmodulin CAM kinase is responsible for upregulating the synthesis of 3 neurotransmitters, dopamine, epinephrine, and norepinephrine. So an antibody is calling for the upregulation of these neurotransmitters. Relapsing remitting symptoms, 3 episodes reported, sudden increase in symptoms with strep exposure. Previous diagnosis was autoimmune disease, not otherwise specified, post-infectious encephalitis and encephalomyelitis, other diseases involving the immune system. This patient had a positive Western blot for Lyme, and as you can see, other infections, elevated mycoplasma and Coxsackie titers. I don't think they got medical history on this one very well. Family history did show that the paternal grandmother had an autoimmune disorder and a history of rheumatic fever. And again, you can see this self, non-self dysregulation, and the siblings had pandas. This case was a little more difficult. The patient was treated with plasmapheresis and IVIG with symptom improvement, low-dose Zoloft, and Abilify for maintenance, significant improvement in the patient's symptoms. You can see the return to normal range of the calmodulin CAM kinase activity. And then one more, 20-year-old female with gradual onset. PANDAS PANS, of course, patient, depending on the age definition, may not be really a PANDAS patient, but because it's a gradual onset, the acuity of onset is a criteria for PANDAS and PANS. Again, medical model here, very similar or very similar types of underlying etiology. You can see the different presentation. This patient had high titers for antibodies directed against the dopamine D2 receptor and elevated activation of calmodulin CAM kinase. Relapsing remitting syndrome, diagnosis was idiopathic peripheral neuropathy, and several others, but she had Lyme disease, positive for strep, Lyme, Babesia, mycoplasma, EBV, herpes zoster. So it is not unusual for an index infection that triggers the immune system to begin to make these autoimmune antibodies. The patient then becomes susceptible to other infections, and therefore many of these are continuing to help trigger the immune system response and the inflammation. The medical history was frequent strep infections since childhood, low IgG and dental infections, positive for autoimmune disease in the family. This patient was treated with 4 courses of rituximab and then ozone treatments. But the rituximab, as you know, will remove all the CD21 positive B cells, which many of them would be those that would be producing these antibodies, or the memory B cells. Significant reduction in the patient's symptoms, and you can see the return to baseline for these patients with the CAM kinase and the anti-dopamine D2 receptor. One last one, and this is published case study by Dr. Bernstein and at Cincinnati Children's. There was a 15-year-old girl who had originally been diagnosed and treated for schizophrenia, psychosis, and anxiety. He reported that she had all dopamine D1, D2, lysogangliocyte tubulin elevations. And after 1 course of plasmapheresis, 7 treatments every other day, the patient had complete resolution of her psychiatric or psychotic OCD and anxiety. She was weaned off the olanzapine, resumed her normal activities, including tennis, within 2 weeks after plasmapheresis, and her response has been supported for over 6 months. We read the report. We asked him if he could send us a patient specimen at no charge. We tested this patient specimen, and all her antibodies had returned to baseline. So let me just share with you a little bit more about the symptoms associated with the autoantibodies, and then I'll see if you have any questions, and we'll pause for a moment here. We know that dopamine D1 receptor and antibodies directed against them typically result in different types of psychiatric symptoms. So we'll see patients that may present with mood swings, depression, anxiety, irritability, aggression, delusions, and even psychosis in some cases. We do see when antibodies are directed against the dopamine D2 receptor, we see movement disorders. Frequently, they may have chorea or these little choreiform movements. They could be diagnosed with ADHD because they just couldn't hold still, possibly even Parkinson's. When patients have autoantibodies directed against lysoganglioside GM1, we see them exhibiting various types of tics and complaints of joint and connective tissue pain. We do see antitubulin fairly frequently. We see when the antibodies are directed against tubulin, which is heavily concentrated in neuronal cells in the brain, they frequently present with different types of OCD, obsessions and compulsions rather, around food, clothing, intrusive thoughts. But one of the more common complaints is brain fog or cognitive complaints. And then, get back here. CAM kinase activity. I mentioned that we grow human brain cells in culture, not the patients, but mortalized cell lines. And then we incubate them with their serum. And we look at the activation of this particular enzyme. Typically what we see, if it's activated by the serum and the autoantibodies, we see basically what looks like is the activation of the sympathetic nervous system. So you'll see fight or flight type of behavior, separation anxiety, bedwetting, mydriasis. And often what we'll find too, not that when the others aren't positive we don't see this too, is that there's still an underlying infection that hasn't been treated or a recurrent infection. So this, although none of these look for infections, they're an indicator that there may be still an underlying trigger. So I mentioned the calmodulin CAM kinase activity. What you can see here is elevation in pandas and PANS patients versus normal patients. And graphically, what you can see here is between the pre and postsynaptic neurons, once these antibodies cross the blood-brain barrier, they can actually interfere, bind, either block, or in some cases, activate these receptors, and then begin the process of these neuropsychiatric behaviors. Won't go into this too much, but there's more research showing that the CAM kinase 2 enzyme is essential for plasticity in the brain, learning, and various types of organization in the brain. And it's been associated with many different disorders, including drug addiction, schizophrenia, depression, epilepsy, and other neurologic disorders. So one thing, though, that we do have, and we began to collect these stories, is patients who have remarkable recoveries after testing and treatment. Grace, whom we have on our website, was diagnosed with ADHD and OCD and a mental disorder at 8 years old and wanted to kill herself. Her parents emptied her 401k twice with no answers. Recently, her mother sent us this picture of her completely well and back to normal life and on the cheer team. Adam is another story who was diagnosed with ADHD, and they thought he had autism. They were thinking they were going to have to institutionalize him. After testing and treating him, their mom sent us this picture and showed us he's running cross country, saying recovery is possible. He's 10,000 times better. So what are the common symptoms of patients that have positive anti-neuronal antibodies and CAM activation in the autoimmune brain panel. We see that they tend to be treatment resistant for standard neuropsychiatric drugs. They could have multiple infections, Lyme, neurologic Lyme, post-treatment Lyme. Typically a family history of autoimmune disorders, sudden or rapid onset of neuropsychiatric symptoms, sudden or rapid onset of OCD, restrictive eating disorders, motor or vocal tics or choreiform movements, anxiety, rage, separation anxiety, emotional ability, depression, and different types of behavioral regression. Sometimes they will have dilated pupils. That's one sign. Typically, that's associated when we see an activated CAM kinase, and urinary frequency. Relapsing remitting is another symptom that we see. And one of our neurologists who works with these children and says that if you ask them, all of them have had suicidal ideation. You just have to ask them, but it is a reoccurring symptom. PANDAS, obviously, PANS diagnosis. So what are the takeaways? And then I'll open for more questions. It is very important to obtain a thorough medical history. And also, gradual onset doesn't necessarily mean they don't have or couldn't have a medical syndrome like this, but it wouldn't be qualified for PANDAS or PANS because it has to be sudden onset. Relapsing remitting, look for a family history of autoimmune disorders, rheumatic fever, Sydenham chorea, or even any other type of autoimmune disorder. Look for restrictive eating disorders, not the classic anorexia, weight loss, just obsessional fears, choreiform movements where the fingers don't hold still. One of the tests one of the physicians do is say, have them close their eyes, hold their hands out straight, and hold their fingers out straight. And if they can't keep their fingers still and they show these piano playing finger movements, this is a choreiform movement. Dysgraphia, loss of fine motor skill. Tics, mydriasis. And then some labs that are helpful, clearly strep, ASO, DNA speed, check the family too. ANA, although it's a general immune, or in this case, it is positive in more than 50% of the patients. Often occult infections, and you'll see many of these infections. And as we're talking about today, the autoimmune brain panel can help in your diagnosis and identifying whether or not there is autoantibodies directed against these targets. So if you're looking for additional guidance, PANDAS and PANS is a good model to look through. And basically the way you look at this here in maybe broad strokes is, first of all, rule out any other causes, establish a correct diagnosis, and then treat all the infections. Be sure you look for multiple infections. And then, if needed, provide some symptomatic relief. Often, if they are on SSRIs, it's a very low dose, just for some control, because they actually don't respond well to normal standard doses. But treat them with anti-inflammatory agents. PANDAS and PANS guidelines, you will see from NSAIDs to various types of steroidal bursts and others. Someone asked about other naturopathic remedies, anything that falls into anti-inflammatory and immune modulatory or immune modulatory agents. IVIG is one of them. Rituximab is another one. Plasmapheresis will remove them. But again, you're looking for things that will treat the immune system, the inflammation, and all the infections. So you can download the guidance for PANDAS and PANS from the Child and Adolescent Psychopharmacology journal that's also on the website of the PANDAS Physician Network, www.pandasppn.org. Also, if you're interested, there's a really good video. Be sure you're not eating dinner or anything when you're watching it, but it's called My Kid Is Not Crazy, and it's a search for hope in the face of misdiagnosis of the suffering about 4 families go through. Very well done by Tim Sorrell at the University of Florida. So we have free clinical consultative support and services. One of our nurses, Amy Cross, whom you saw as the moderator today, for clinicians, you can call the direct line there listed, or email at crossa@molecular.com. For any kind of operational questions, call our office, or we can put you in touch with a nurse. We have 2 of them on staff to help with any questions related to the testing and even the results. We have free education on the association of the biological targets. So we can do in-services for your clinic or for your colleagues. And we have free brochures that can be downloaded from our website, and other hard copies that we could send to you. We started the company as a response to the outcry of a clinical study that ended, and patients who had gotten well told other patients and parents who could not get into the clinical study. And so our goal here is to help transform how medicine is practiced for those suffering from these neurologic, psychiatric, and behavioral disorders. And we're constantly doing research and development on better understanding of these, as well as looking at ways to increase the knowledge and the understanding of the pathophysiology of this disorder. So with that, I will end and open it up for questions. Again, thank you for attending. Thank you for listening. Thank you for being at the front line and taking care of these often very, very sick and chronically ill patients. But there is hope, because when you understand what the root is and you treat the root, patients can get well. Amy, I would like to see if there are any questions.
Thank you, Dr. Shimasaki. We do have a couple. Suzanne asks, as psychiatric medications come with a raft of side effects, are these generally more inflammatory rather than helpful in autoimmune conditions? And have we seen relapses in those treated only with single agents?
Yeah, that's a really good question. In general, the symptomatic treatment through typical psychiatric medications are not very, patients aren't very responsive, and in many cases, they actually negatively respond to these at standard dosages. Mentioned that low dose SSRIs often are used to help, and you'll see in the Journal of Adolescent and Psychopharmacology, they will list some of that. So there is a place for that, and there is a means for that. But again, in these cases where they're immune mediated, it's more to help with symptoms temporarily at low dosages, so that you can take care of treating the underlying infection and the immune system. Have you seen relapses in treating those with single agents? I think the relapses are typically if the drug in this case is masking the symptoms, then once they're off it, clearly, yes, you'll see that, because the underlying root would not have been treated.
Thank you. Another question. Do elevated strep antibodies necessarily indicate a current infection?
Yeah, so ASO DNase-B. So you take you can take a rapid strep test, and clearly, if that's positive, you can see that that's an active infection. You're really looking at for IgM antibodies for strep, but often, sometimes, because strep can hide in any orifice, you may not see a positive for strep. Although what's being attempted to get into that is patients or children with neuropsychiatric syndromes that their PANDAS Physician Network and others would like to see, as should be, a strep test as something that would be incorporated into this. But again, if it's positive, you've got some really good evidence that you should treat the strep. If it's negative, it does not necessarily mean that you may not have a strep infection somewhere, and or you may not have you may have a Mycoplasma coxsackie, Babesia bartonella infection that have not yet been identified. So identifying infections are a very important part of the treatment.
Yes, I'd like to add one quick note. We often hear from our prescribers that doing an ASO, a DNase B, as well as a vigorous throat swab is useful, as none of the strep tests is 100% accurate yet. There are, many people working on strep vaccines and better strep testing, but the inclusion of all three evaluations are more likely to give you a true picture.
Let me add one other thing, and that's great, Amy. Thank you for that. This is one of the things in which, when people talk about controversy about pandas, is because 90+8% of children get strep. So why doesn't 98% plus of them get pandas? Well, again, we know that this has to do with the immune dysfunction and the antibody stimulation and things like that. But there can be, just because it's positive, it may or may not be, it could be a comorbidity. So what typically you want to see if you're going to be monitoring these, and that is, you're going to look for the rise and fall of these strep titers with these different types of neuropsychiatric behaviors. They may or may not be related to each other. Like you can have comorbid or other types of things. You could have a case where a patient could be just atypical neuropsychiatric and have a strep infection. So obviously you'll want to treat that, but it may or may not necessarily mean that the patient might have pandas or pandas. So it is one of those things that has contributed to what people think about the controversy, because there has to be a clear association with that. But again, strep isn't the only trigger.
Thank you. And one final question. Is there any specific stage of this condition where plasmapheresis might be more effective? And what is the success rate?
Yes, we do know some physicians who predominantly use plasmapheresis in these cases that are sent to them, and they do have really great success. It typically is under the criteria that if there's an infection, it's been identified and treated, and or they have tried other things, because there's always risk with every type of treatment. But if you think about plasmapheresis, what you're doing is you're removing all of the antibodies from the patient. So typically you will see and do see some very good responses if this is the case. If the underlying infections aren't cleared, there is the possibility, and can happen, that these just then return and you start seeing the syndrome reoccur. But plasmapheresis has been shown to be effective. There's an older, I think it's a Lancet article comparing plasmapheresis, IVIG, and a placebo in these patients. And you see the biggest change in the Y-box score of these patients with plasmapheresis. Then you see another great drop with IVIG, and of course, not so with the control.
Thank you, Dr. Shimasaki. We are at 3 minutes over, so I'll take this opportunity to thank all of our attendees. Our recording will be sent out to everyone who registered and or attended the webinar, and we look forward to interacting with you again soon. Thank you all. Bye-bye.
Thank you. Bye-bye.